Good evening and welcome to the August 2025 Cure JM Town Hall entitled First Steps Forward. Get some expert guidance for newly diagnosed patients and no doubt some important information for all of us. Before we dive in, I want to give a quick word of thanks to our corporate sponsors that you can see listed here, and also to draw your attention to some of the clinical trials that are currently in process and enrolling patients like our kids. You can find that information at the website, web address that you see here. Following that QR code will get you there. There are exciting trials underway right now for CAR T, also for CAR NK and anifrolumab, and you'll find information there on the site about an exciting new trial beginning to enroll patients at the beginning of October for a JAK inhibitor called deucravacitinib. We're all really excited about that one. Tonight, we are honored to have three devoted clinicians with us. Dr. Megan Curran from Colorado Children's has been a cornerstone of JM care and research for 15 years now. Her involvement with Cure JM has been critical over this last decade and a half. Dr. Angela Chun from Lurie Children's in Chicago and Dr. Belina Yee from Johns Hopkins in Baltimore both serve on the steering committee for our clinical care network. All three of these esteemed clinicians serve in that body of about 60 clinicians from around the world, and they are working to help shape the future of care for families like ours nationwide. Dr. Chun, will you kick us off?
So this is our agenda for tonight. So whether you are a newly diagnosed family or just somebody who wants a good refresher on kind of the ins and outs for JDM, this is meant to be kind of a nice, right, introduction to the disease as well as the treatment journey. And so hopefully it's a good overview. And at the end, if you have any specific questions, we're happy to answer. But James, next slide. Really quickly, we're just going to introduce ourselves. So, like James said, my name is Angela Chun. I'm here in Chicago at Lurie Children's and Northwestern University. I did my pediatric rheumatology training at Texas Children's with Baylor College of Medicine in Houston. And then I recently came back to Chicago to join as faculty. So here in Chicago, I took over our myositis center and biorepository, as well as I'm part of the leadership team for our fellowship program.
Oh, and that's me. I'm Megan Curran. I'm currently a pediatric rheumatologist at the University of Colorado in Denver, but I worked for 9 years at Lurie Children's at the Cure JM Center of Excellence, and had the privilege of learning from Dr. Lauren Pockman. And I did my pediatric rheumatology fellowship training at UC San Francisco. And my job now is working with patients and leading our fellowship program, our training program. And I also run the Elf on the Shelf for our clinic workroom.
Hi, I'm Belina E. I'm a pediatric rheumatologist at Johns Hopkins. I kind of lived all over the country. I actually trained in California at Children's Hospital Los Angeles. I've been mostly interested in obviously juvenile myositis research, focusing on calcinosis. I also regularly attend the George Washington University Cure JM clinic with Dr. Lisa Ryder and Hannah Kim. So that's been a privilege to work there with them and learn more about juvenile myositis.
So let's start off with basics, right? So we are Cure JM. So the JM stands for juvenile myositis, but that's a big umbrella term, right? So myositis is a big fancy way of saying inflammation in the muscles. And we like to break it down into some buckets. And so the most common type of inflammatory myopathy is JDM or juvenile dermatomyositis. And we'll kind of talk a little bit more in detail about what all these different terms mean. But the other kind of two big buckets are juvenile polymyositis and then overlap myositis, which is what we call when we say that you have feature of not just myositis, but other autoimmune conditions like lupus or Sjogren's or other kind of overlap syndromes. Next slide, James. So whenever we talk about juvenile dermatomyositis, so dermato means skin, myo means muscle, itis means inflammation. And so the kind of two big hallmark features that we see in JDM are inflammation in the muscles as well as the skin. And so whenever doctors are trying to make the diagnosis, we look for those kind of patterns. So we talk about proximal muscle weakness, which what we mean by that are usually the first muscles that get impacted are kind of your big muscles as well as your kind of biceps, triceps, as well as your quads. And then we also look for kind of characteristic or classic rashes, as well as we take a good look at your nail fold capillaries, which we'll talk about in a few slides. But then for comparison, James, if you go to the next slide, whenever we talk about, oh, sorry, and the one subtype of JDM is sometimes what we call amyopathic dermatomyositis, which is a big fancy way of saying that you don't really have a lot of muscle involvement. So maybe you're not super weak, but you do have a lot of those characteristic rashes. So you seem to have a lot more of the skin predominance in terms of your flavor of JDM. And then, James, next slide. For comparison, the opposite is juvenile polymyositis, or when you really have just, it seems like muscle inflammation and not so much the skin. Next slide. So, how do we make the diagnosis? The one thing I truly believe that if you train doctors how to recognize, right, those characteristic findings on your history and physical exam, you can make the diagnosis in a clinic, you can make the diagnosis in an emergency room. You don't need to have a bunch of fancy tests to make the diagnosis. But as we're going to talk about, every JDM or myositis patient is slightly different. So you might not fit the kind of classic textbook symptoms that we're looking for. But in terms of the rashes, right, the kind of big ones that we look for are something called the heliotrope rash, which is often around your eyes. And I want to include photos because it looks a little bit different based on your complexion, right? So if you're very fair skinned, you might have really big, obvious, either red or kind of purple like discoloration around your eyes. Versus if you're darker skinned, right, it might be a little bit different in appearance. And I like the photo at the bottom as well because some kids who have this rash can also get a lot of swelling in the area too. So that's the rash that tends to be over your knuckles. And again, if you're fair skinned, you might have, right, very erythematous or very red kind of raised skin or kind of bumps on over your knuckles. Versus sometimes if you're darker skin, right, you might not have a lot of pickup on the color changes that happens after the inflammation, which based on your complexion might be either darker skin or lighter skin, but you can see that it's the same kind of location or same distribution. Great. So this is a slide that talks about nail fold capillaries. And so you might notice during your doctor's visits, we take a close look at right underneath your fingernails or your cuticles because we're taking a close look at the blood vessels. And so the picture at the top is what it looks like if even without a scope or a magnifier, like you can see, right, there's the kind of big kind of areas of redness. And usually to see your blood vessels without using a magnifier. But we use something called a dermatoscope to take a closer look at your blood vessels. And the picture on the left, or the picture that says A in the corner, is kind of what your blood vessels should look like if you look with a magnifier. And so if you think about bobby pins that girls put in their hair, right, it's the same kind of shape where you have that kind of straight and then curves and it comes straight down. And it looks like almost a bunch of bobby pins kind of lined up next to each other versus the picture labeled B on the right. Some of the features that we might see in JDM, where we see, right, a lot of areas that look extra squiggly, or some areas look extra swollen, or there's some areas where you don't even see blood vessels, or you see a lot of kind of dropout. And so those are all changes that we can see for JDM, and those are things that we kind of continue to monitor as you get treated to look for subtle signs of either continued inflammation or signs of damage. Next slide. And then there are things that called myositis specific antibodies, which you might hear some doctors talk about. So as doctors, right, we love acronyms and we love alphabet soup. And so you might hear us say a lot of different numbers and letters. But what we mean about these antibodies is that you don't have to have a positive antibody to get diagnosed with juvenile dermatomyositis. But we do know about some antibodies where we test you for it because if you're positive for that, it tells us a little bit more about your kind of flavor of dermatomyositis. So it kind of gives us a little bit more of an indication of what organ systems might get involved. So we monitor a little bit closely. And some subtypes might be more rash versus more risk for calcinosis. So again, you don't have to have a positive antibody to get diagnosed, but if you do get a positive antibody, it just helps us know what to expect potentially in the future as we get you treated. And again, these are some more of the kind of common subtypes that we see in pediatrics. But again, you can see that picture on the right where it says antibody negative. And again, you can see a lot of the similar kind of characteristics or manifestations. And so, again, it's always good for us to know because it's extra information. But no matter what your subtype is, right, we continue to monitor you head to toe to make sure that we know how your JDM is impacting you both now as well as in the future. Next slide. So shifting a little bit in terms of labs. So we're going to talk about a bunch of labs because, right, whenever you go to your doctor's appointments, you're probably getting a lot of blood work done. And it might be really overwhelming to kind of see all those results come back because you might see a lot of things flagged in red that might not actually. And so we're going to kind of go over kind of big picture what we're looking for in the labs and kind of what the markers are. So next slide. So starting with the muscle enzymes, right? So a lot of times you have muscle inflammation with dermatomyositis or with juvenile myositis. And so we look for blood markers of muscle breakdown or muscle irritation. So the one that most people talk about is the creatinine kinase or the CK, you might hear people say. And that is one of the muscle enzymes where it peaks really quickly and then it can also normalize really quickly. And so the important thing to remember is that a lot of these muscle enzymes, they kind of peak and go down at different time points. And so it's important that we kind of get all of them at the same time to get a better understanding of your muscle inflammation. Because sometimes if we just check the CK, it might not be the most representative number. And so it can go in both ways in terms of if you are a really intense athlete and you work out a ton right before you get your labs drawn, you might see a little bit of a bump in your CK. And it might be because you have a little bit of irritation just more from physical activity. And then same thing as the opposite is true in terms of sometimes with our patients with dermatomyositis, if they have if it's taken them a long time to kind of get a diagnosis and they have a lot of almost like burnt out muscle disease or a lot of chronic muscle disease, then we might actually see low CK numbers instead of high. So again, it's always important to remember the time points whenever we're checking these numbers. But the other muscle enzymes that we look for are things called like the LDH and the AST and the aldolase. But sometimes it's tricky because things like the LDH and the AST, it's not 100% specific to your muscles. And so other things in your body can sometimes cause those numbers to get bumped up. So again, we always try to look at it in the context of all of them together. And then I did forget to mention at the beginning, right, the parentheses with the arrows in red. What that's supposed to indicate is the pattern that we look for to kind of indicate active disease or kind of inflammation. So if you have a lot of muscle inflammation, we expect all of these numbers to be high. Next slide. Other muscle numbers that you might hear us talk about. So these are some muscle tests that we either as rheumatologists do, or sometimes we have our physical therapists do them as well. But these are kind of objective scales that we use to help quantify your muscle weakness. And so the CMAS or the Childhood Myositis Assessment Scale, I like to think of this as kind of like a mini Pilates class because if you watch us do it, right, it's a lot of kind of doing a certain position and holding it for this amount of time. And so this is a really good indicator of muscle endurance. And so the maximum number of points that you can get is 52. And again, you can see that red parentheses shows that it's low. So that means that if you're really, really weak, you're scoring. So ideally with treatments, you'll see that number get closer and closer to 52. And then the other big muscle test that a lot of different centers use is called the MMT8 or the manual muscle testing of 8 muscles. There's a little bit of variation in this test based on your location. And so here in Chicago, our max is 80. But in other locations, they might use slightly different numbers. So it's always good to know with your doctor kind of what the max number score they use there. Um, Testing on how strong certain muscles are. So both of these tests, even though they tell you a little bit about your muscle strength, they tell you a little bit different things, right? In terms of muscle endurance versus just like pure strength in those muscles. Next slide. Markers of inflammation. And so sometimes, especially at the beginning when you first get diagnosed, you might have so much inflammation going on that we see signs of inflammation in your blood, but it's not always the case. So these are some of the examples of things that we can see on your blood work to show signs of inflammation. But again, every patient is a little bit different, and you might not show all of these different abnormalities. But the white blood cell count, when it's high, can sometimes indicate inflammation. Versus, again, if you've had inflammation for a long time, you might start to get a little bit anemic. So your hemoglobin might be a little bit low. The C reactive protein or CRP, that's another indicator of inflammation, and that tends to be high, as well as your erythrocyte sedimentation rate or your ESR, that also tends to be high. The important thing to remember though is, right, a lot of our juvenile myositis patients get IVIG as part of their treatment. And after you get IVIG, that actually makes your sed rate kind of not easy to track because it's going to make it go high because of just the way that the lab works. And so if you start IVIG treatment and then all of a sudden you're like, whoa, my sed rate jumped up a ton, it must mean that I'm flaring. It's probably because of the medication. So again, it's always good to remember that we don't treat numbers, right? It's always kind of the context of what was happening when we drew those numbers. Next slide. And then depending on where you are, there are some specialty labs that some doctors may send. The kind of tricky thing with myositis, right, and the reason why we kind of dedicate so much research into myositis is we know that there's unfortunately no perfect lab that we can continue to follow that is consistent and reliable for every single patient. And so there's a lot of really smart doctors trying to figure out, right, what's a good blood test that does show if there's signs of inflammation, even if it's subtle, once you start treatment. And unfortunately, don't have a great answer just yet. But these are some of the other labs that sometimes you might get seen sent. So the von Willebrand factor antigen, that can be a marker that we see with inflammation in the blood vessels. Look at the parentheses. If it's high, that's what we expect with the flare. A neopterin level, again, depending on where you practice, that might get sent. And again, we expect that to be high. Here in Chicago, we pay attention to the NK cells, and we tend to see drops in those with flares. And then again, I know in other locations, they might send other specialty tests like the galactin-9 or the CXCL10. But again, depending on where you are, sometimes these labs may not be available because some of them might be either specialty labs. But again, we're all trying to figure out what is the best lab test or what's the best combination lab test that we should be following for our patients with juvenile myositis, especially after you get the diagnosis and start treatment, because sometimes it can be really tricky to know for sure that we have all of the inflammation under control. In terms of other general health maintenance labs, right? So we care about your vitamin D levels, and that's partly for a lot of different reasons. So one is you might hear us harp all the time about sunscreen. And so usually the way that your body kind of synthesizes vitamin D is from the sunlight and UV radiation. And so now we're telling you that you have to cover up and wear sunscreen all the time. So that sets you up for being a little bit higher risk for low vitamin D levels. As well as we know that, right, things like chronic steroids can also impact your vitamin D levels, and just having long-term kind of inflammation can also be bad for your bone health. So we always make sure that we kind of check in on your vitamin D levels at least once a year to make sure that you don't need any supplementation to make sure that you have the best bone health. And then another kind of surveillance lab that we may look at are your kind of cholesterol or your lipid levels. And that's because long term, we know that our patients with juvenile myositis might be a little bit higher risk for things like high cholesterol or kind of other metabolic syndromes. And so we like to check in at least once a year to make sure that we're in a good zone. Next slide. So, what about prognosis? So this is data that you might hear some people talk about, but it's based on one study by a group in Canada, and it was published back in 2000. So it is a little bit outdated, which is a little bit crazy to say because in my head, right, we're still in the early 2000s, but now we're in the 2020s. But you might hear people reference that about one-third of kids with JDM do go into remission in terms of they get diagnosed, they get treated really aggressively for a few years, and then they're lucky and they're able to stay off medicines and be well off of medicines. Versus this group found that about two-thirds of patients had more of a chronic course. And so, right, they get diagnosed, they get treated, and then maybe while we're trying to come down on medicines, you have another flare up. And it seems a little bit more of that kind of rocky up and down course. And then within that two-third group, they found that about like 3% had what they call a quote unquote polycyclic course. And so what they mean by that is that you have a little bit more of longer periods of remission, but you do kind of continue to need medications here and there. And so you get diagnosed, you get treated, able to come off medicines for maybe a couple of years, and then you have another flare up, and then again, you go into remission. Um, and I've heard some families ask, right, because they say, hey, like I've talked to a lot of other families, and I really don't feel like I've heard a lot of patients going into this one-third group of, right, having that kind of one and done course. And they ask, right, why is that? And I think it's a tricky question with tricky answers, right? I think part of it, though, is as doctors, right, as we get better and better at recognizing the subtle signs of dermatomyositis, we might be realizing that even when things seem quiet in terms of, right, you're strong, and you don't have a lot of obvious rash, we still worry that you might have a little bit of smoldering inflammation. And so we're kind of adjusting as doctors in terms of getting a better idea of when it's the best time to try to come off medicines that might, right, give you the best shot of being in that first group of being able to stay off medicines. But also being a little bit more cautious, right? In terms of we know that treating aggressively and kind of treating, I would say, longer at the beginning, kind of again, gives you the best shot of kind of having your immune system get calmed down and then stay calm even when we try to come off the medicines. Next slide. So overall, right, even though there's no way for us to know or be able to predict, right, if a patient is going to be in which of those groups, we do know based on these past decades of treatment and research that the earlier we treat and the more aggressive we are at the beginning, overall better outcomes. Because the thing that we want to avoid is any kind of long-term damage, whether that's in your skin or your muscles or your endocrine system. I think the hopeful things to keep in mind, right? Even compared to 2 decades ago, we have gone from 30% to less than 3%. And then the other thing that I always like to highlight for our new patient families, because I know everybody Googles, one of the first things that pops up when you Google dermatomyositis is a lot of scary things about associated cancers. And that's because on the adult side, dermatomyositis has been associated with an increased risk for cancer. But fortunately, on the pediatric side, we have not seen the same kind of strong association. So that's one thing that I always try to let families know. Because again, I know the internet can be a scary place. Next slide.
All right, thank you, Dr. Chun. I'll take over from here. We're going to be talking about some different treatment approaches. Next slide. So first, we'll kind of touch base on the first line medications that are the most common ones. Of course, there are new medications and other medications that are used that your family or your child might be on, but these are the still remains the most common first lines. First is the steroids, and then when we talk about steroids, obviously you know, but we're not talking about those that make you bulky. These are the type of steroids we use to decrease the inflammation. And the ones we use are usually come in two types. The first one is IV or intravenous. That's the one you get from like through infusions, like the little girl on the picture right there. Or you take it by mouth, meaning a pill or liquid you drink. And then on the doctor's note, you'll see that we call it oral or PO. The second one is methotrexate. And then, yeah, this is a really old medicine that's been around in pediatric rheumatology. And again, if you Google this, patients tend to get really scared because they will say that it's also a chemotherapy. And then I always tell my patients that it doesn't mean that you have cancer. Sometimes we just share medications with other specialties like oncology doctors. But basically, what methotrexate does, it kills off some of the immune cells. And that's kind of what we want to do when somebody has an autoimmune disease because your immune system is too excited and confused and attacking your own body. So we're basically telling the immune system, hey, you're going a little crazy. You need to calm down, like Dr. Chun was talking about. So by using a little bit of medications like methotrexate, we help inflammation to go down. And usually it also comes in two forms in treating juvenile myositis. First is oral, like I said, usually in the pill forms, although you can also drink the injection form. The injection form, you'll say that we call it subcutaneous or SQ on our doctor's notes. That just means that it's just we try to get the medication right a little bit below the surface of the skin. So usually when we talk about methotrexate injection, the needles are tiny, very, very small needles that we usually use if you have any family members with diabetes, it's kind of like an insulin needle size. It's not as big as, the ones that we use for IVs or the ones you get when you get vaccinations. And then, of course, the other one is IVIG. It stands for intravenous immunoglobulins. Intravenous because we often get it as infusions, kind of like the steroid, how we had the IV form. Immunoglobulins are basically, I like to think of it as like a proteins that are involved in immune systems, like immune proteins. Because in the immune system, as you probably are learning right now, it's not just, white blood cell counts and going and killing things. There's a lot of other types of proteins and processes that happens, and immunoglobulins are part of them. And they're actually not made, IVIGs are not made in lab or in a factory. It's actually derived from donations by people. So basically, these are immune proteins that are not confused because the ones in juvenile myositis are confused and wants to attack your body. But these are not the confused ones that we're giving it to our patients. And kind of like by doing that, we're trying to guide the immune system like, hey, like, here are the right ones. Like, they don't want to attack their own body. So they're kind of like guiding to decrease the inflammation and guiding the immune system to the right way. And the next slide. And these are the very exciting medications that you might be already on, or your family might be already been on. And there are a lot of them, and we won't be going into the details of it. I just wanted to kind of show it in the slides. And you can see that I always have like two different names. The first part is like the generic name, and then the within the parentheses is the brand names. So you might see like different names in your doctor's chart, but usually it could mean like they're the same drug. So it's confusing, but kind of think of it as like a Tylenol and acetaminophen. Some medications that are more common that you might heard of are like mycophenolate or Celsep. If you have been reading about juvenile myositis or heard about any talks, I'm sure you heard about drugs, a family of drugs that are called JAK inhibitors. But there have been a lot of talks in CureJM providing details about these medications. And if you're interested, we can also provide more information on certain medications here. Next slide. Um, Thank you. So, usually when we talk about treatment phases, we're talking about induction, tapering, and maintenance. And what that means is for induction, basically, this is when we usually diagnose patients, and this is when their inflammation is the most like powerful in attacking the body a lot. So this is when we are like, okay, there's a like big fire of inflammation happening. We're gonna hose it down. So usually this is when we use things like IV steroids, which is really good medicine to calm down the immune system very, very quickly. And then here I just mentioned like methotrexate and IVIG because like I said, these are still remains to be one of most common medications. But on top of the steroids, usually doctors will start the patient on other medications like methotrexate or IVIG while hosting the inflammation down. And then the part on the tapering is when, okay, like we just sprayed you with all this water, but we're not going to spray you with this water forever because, then it's gonna get flooded and cause all these side effects. So then we try to, tapering is when we try to wean down on medicines. First, we always, as rheumatologists, we always try to wean down steroids first because it does have a lot of chronic side effects that we'll talk about a little bit later. But sometimes it's difficult with juvenile myositis because unfortunately and fortunately, juvenile myositis do respond really well with steroids. So it might take a little bit long to wean down on the dosage, but that's usually the goal. And not just the steroids. Sometimes your doctors might want to wean down on other medications like methotrexate or IVIG. And then the maintenance phase is when we feel like this is a disease that has been controlled. Um, this stage for some people might be that you're still remained on some medications. It could be methotrexate or other medications. Or you might be even still on a little bit small dose of steroids or even IVIG. But for some patients, like Dr. Chun talked about, if you could be on one of the more monophasic type like patients, then you could be off of all the medicines and then could be considered a remission. I think it's important to remember that all the patients might look different on whether they're on induction, tapering, or maintenance phase. And next slide. And this also kind of shows, if you click one more, James, it's not always a straight line either. Sometimes it'll be like, you're in induction. And then, you could be like, okay, now I'm gonna go to the tapering stage. Okay, like we're going down on the medication, so now I'm gonna be on maintenance. But sometimes, like what we call disease flare can happen at any time of this time. The disease flare mainly means that you're at a certain stage of your disease, and then something happens, something that will activate your immune system. Typically, we see it a lot in acute infections. Like you have JDM on these medications, and you get a little cold, and that just activates your immune system, gets your myositis worse. And so, a lot of times, the it's not always a straight line, and sometimes you will be at induction, and before you're just going to tapering phase, you end up flaring again and then going back and forth. So again, I don't want anybody to be discouraged just because, oh, like I thought I was supposed to be in like maintenance now, but I'm still not there, or I was there and now I'm back on like induction. I feel like I'm back on induction phase with all these thick medicines, but everybody's different and it can vary a lot with each patient. Next slide. So I did want to talk a little bit about the side effects on the three main common medications that I had mentioned. So corticosteroids, like I said, the steroids are great medicines to decrease the inflammation, but they do come with a lot of side effects, and here are some of the ones that I wanted to mention. And James, if you could click one a couple times more, and I also wanted to discuss something that you can try to do to help with this possible side effects. So a few things that I want to mention are first thing is stomach ulcers. So steroids can really stresses out your stomach. And then it might be kind of some of these helpful tips can sound a little silly because I'll tell my patients, oh, you should like take it with food. Um, and also, um, and also, the doctors might give you some medications that they call stomach protectors. So these can be medications such as omeprazole or famotidine. And then a lot of patients who go on steroids do gain weight. They tend to gain a lot of weight, and some patients even develop type 2 diabetes. And also, again, it's a bit silly to say, but then we encourage them to try to keep the healthy diet. Part of the reason is when patients start taking steroids, they just crave sugar. They're always hungry and they always want to get snacks and they want, so it's a little, might be a little helpful, like when they're like, I'm hungry, I'm gonna go find something to eat, and they open the closet and then or cabinet, and if you have more healthier options, that might be actually be helpful. And then the the bones can get really weak when you're on steroids for a long time, and that's also part of the reason why Dr. Chun had talked about. We really keep an eye on vitamin D levels, and then we also provide vitamin D supplements, and also sometimes we give calcium to help keep the bones strong. And when you take steroids, a lot of times patients do have difficulty with sleeping. And then actually, it's not just with steroids. Any children going through chronic diseases because of the stress and anxiety, a lot of children go through sleep disturbances. And again, sounds silly, but it's really these everyday things. Everything counts. Sleep hygiene has been actually even difficult to do these days because of so many electronics that are available. And, everybody has their phone. And I mean, I'm guilty also, but it's just like hard to like get that phone down and then keep everything dark to help you fall asleep. And then cataracts are also another side effect of steroids that so you might think like, okay, my child has myositis and I have a rheumatologist, I'm good to go, that's the doctor we have. But actually it's really important to keep going to other regular doctors visits, including like eye doctors and dentists and your regular pediatrician, especially. Those doctors all keep an eye on things like the high blood pressure. I have here too. Of course, as rheumatologists, we'll be taking the high blood pressures. We'll be taking the blood pressures and keeping an eye on how high they are, and refer to the if a kidney doctors if needed and things like that. But it's also important to keep all these things monitored with your routine doctor's visits. Next slide. And the methotrexate. Oh, methotrexate, another medicine that helps, but also gets a lot of, discomfort. Most patients really have difficulty with nausea and stomach issues. The first thing I want to mention is don't forget to take folic acid, or some form of folic acid we call leucovorin, and you take it the day after. You might think like, well, I'm taking methotrexate. What is this folic acid that my doctor gave me? I don't know. I don't know what it is. I'm just going to take my medicine that's for myositis. But folic acid or leucovorin, they really help with the side effects. And that's like part of the reason why we give it to you. And in fact, if there is a lot of side effects while you're on methotrexate and folic acid, you can ask the doctor to increase the folic acid dose a little bit, or even double the dose and see if that helps. There have been some concerns that if that decreased the effectiveness of methotrexate, but then actually how methotrexate gets metabolized in the body, it shouldn't really affect that much. And another thing that I recommend is try taking the methotrexate in the evening, so that maybe you can kind of sleep through the possible side effects that might come, rather than when you're awake, you'll be kind of paying attention to what's going on in your body. So that we found that it's helpful for some of our patients. Another thing you can try is splitting the dose, meaning that, for example, usually methotrexate come in like very little pills, like 2.5 milligram pills, and you end up taking like 6 of them. You can try taking maybe like 3 in the morning, or like 3 in the evening, or 3 in the afternoon, or 3 in the evening. And we also found that doing splitting doses like that can sometimes help with the avoiding the side effects. And then, of course, because some of the most common side effects are related to the stomach, we do encourage patients to explore the injection option if they're having a lot of stomach issues. As you can imagine, pills you take it, then it has to go through your stomach and to be metabolized. But injection form is basically bypassing that part. So we do find that there is less side effect like GI or stomach side effects when you use the injection form. And then, of course, you can ask for some anti-nausea medication and see if that helps. Of course, if you're finding that you're needing it, every single time you take methotrexate, then of course you should try to look into if there's any other options. But that is some if you feel like you want to have something in your back pocket, I think that's a reasonable thing to request your physician. Next slide. And then IVIG, again, a good medicine that does cause a lot of side effects. The most common side effect is headache. Um, the first thing we recommend is fluids, fluids, fluids. We do notice that drinking lots of fluids and getting IV fluids during the infusion really help preventing the side effects. So even your doctors probably will order some fluids with IVIG, but then we encourage patients to start drinking lots of fluids. I mean, they should always be drinking lots of water, but even more, even from the day before, and then bring, their own water to drink at the infusion center. And also you can ask the doctor to see if they can slow down the rate. And this sometimes meaning that you might have to divide the infusion to 2 days or even 3 days, because typically IVIG infusions do already take a while. It usually take hours. But then if you decide to slow down the rate and it really helps with the side effects, sometimes patients end up doing it rather than just 1 day a month and dividing it to like two or even 3 days a month. And then I might have mentioned before, but giving steroids during the infusion of IVIG do help with avoiding the side effects. So it's also something you can ask your doctor. And then interesting thing is you can also ask about other brands. So although IVIG is like a donation, actually there are a lot of different companies who distribute IVIG, and there are different brands, and some people develop side effects on certain brands. So if you feel like, oh, you want to try a different brand, you can ask your physician or your insurance to see if you're eligible to switch to some other brand of IVIG. And then, of course, you can ask for pre-medications that if you're not already getting them, those are the Tylenol and Benadryl. And actually, after the infusion, you can give at home, you can give your own like Tylenol Motrin for about, or kind of around the clock if you found that you're having a lot of side effects or your child is having a lot of side effects. Kind of rotate the Tylenol Motrin after infusion for about 12 to 24 hours. Next slide. And then I want to talk about sun protection. Beautiful sun, but it's our enemy, unfortunately. Next slide. So, unfortunately, we did find out that the sun, the UV light they really like to flare our autoimmune diseases, especially juvenile myositis. Oftentimes, I ask the patients to put on sunscreen, and they're like, "Oh, I'm not wearing sunscreen. It's winter." Or they'll be like, "Oh, I'm not wearing sunscreen today. It's cloudy. Dr. E." And I'd be like, or they'll be like, "I don't know. I never go outside. I'm always home." And I'd be like, okay, yes, that's true. But actually, the sun and sunlight is everywhere, even in cloudy days. There are UV lights. Even it's winter, UV lights are there. So we encourage people to always have a sun protection, whichever weather it is. And also, especially if you're outside, you have to reapply it every few hours. Nowadays, a lot of fancy things are available at our palms. There are different apps, and you don't even have to like buy them. I mean, like the Weather Channel, they'll give you like the different UV scores for a certain time of the day. So if you feel like your child really hates any type of sun protection, but they do want to go out and do some activities, then you look at your app, you're like, okay, at this time of the day, like looks like the UV score is super, super low. Those will be some other tools that you can use. Next slide. Yeah, and I do want to point out that there has been some false rumor that sunscreens are not safe, and we're here to tell you they are safe. And then sometimes patients ask me like, what do you recommend? What's the best sunscreen? And I'll tell them, well, whichever your child will wear it over and over again. So you can take them to the drugstore and then have them smell these different sunscreens and have them pick one out. If you really, really ask us, we did find out that mineral-based ones with zinc oxide or titanium dioxide do provide a better protection than other ingredient-based ones. And there are also apps like EWG's Healthy Living that gives you kind of different list of sunscreens. And if you click maybe one or twice, James, um, there is also a link on CureJM that has all these different products and resources that you can use for some protection. And of course, there are hats and umbrellas, and there are really cute UPF clothing nowadays, and even wash-ins that a solution you can put in when you wash the clothes, and they'll kind of become like a UPF clothing. Next slide. Yeah, so this is just I wanted to point out from the next slides. We do want our patients to have a voice and have a control of their own body, their own and their own disease. And it's sometimes it gets really overwhelming, and it's good to have something written down. Now, I mean, this is like it says, like this is a sample that I actually got from the CureJM website, and you can make your own. Nowadays, you can get it on your phone. There are apps for this to kind of keep records and making sure that you're taking all the medications. And you can also show your doctors that, we've been doing this. What is there any changes we should make? And if we go to the next slide, um, there are other things that I want you to feel empowered with, because doctors, yeah, we love science, and this disease is interesting, but we're here to treat patients, not the disease. So tell us, like, I hope, all our patients feel feel open enough to tell us what's been going on, like what's going well and what's not going well. And then it's always good to take notes whenever you think about a question. I feel like there's always a time where you're driving home, you just got in the car after doctor's visit, and your child's like, oh, I forgot. I was going to ask Dr. Yi about this question. And you're like, oh my God, like we just left the office. Now I have to go back and call the office tomorrow, or I'm gonna message the doctor about this question. So it's always good to take notes. And then also the school year is coming up, and we have different resources. And if you haven't heard about them, you can ask about them. There's a plan called 504 plan for the government provides in schools, where they are required to provide accommodations in children with chronic diseases. There are also different types of hospital-based resources, state-based resources, and also for infusions, there are home infusions. And with doctors nowadays, we're getting more familiar with the telehealth if the travel is really difficult. Next slide. And yeah, this is just something that I just made up from like the ChatGPT. So you can make your own. You can make it fun with your child, and you can bring it to your doctor and talk about it.
All right. So I'm going to talk about building a care team. Next slide. So this is what we'll talk about, and I'll go through things fairly quickly so we can have a little time for questions at the end. Next. So I think this is a good segue with what Dr. Yi was just talking about. Um, Getting the most out of your clinic visits. So thinking about what you want to talk about before you walk in. Um, Writing down your questions ahead of time. If you are someone who is a documenter or you like data and numbers, bringing a summary of the kinds of things that you've observed, the things that your child has been telling you, um, your observations as parents and your child's observations mean so much to us. It's really important. Taking pictures of rashes, it can be helpful to make a separate album in your phone. So when you just take pictures, then later pull them into an album and arrange them chronologically. Um, you can also get creative about trying to take pictures in the same place in your house with the same lighting. If you're really trying to show us some nuances of what's going on with skin rashes, because invariably the skin will look different when they come to see us in clinic. Um, Really thinking about medication side effects if things are going on, asking us what kind of things can we change. So Dr. Yi talked about different methotrexate tricks that we have. There's even some other ones. Sometimes we just have to bail on a medication if the side effects are just too much and it's making everyone miserable. There may be another medication that's going to work just as well. So don't, so feel empowered to speak up when things are bad. Methotrexate for sure is notorious. About 50% of kids who take methotrexate really have a hard time with it. But like I said, there's various tricks, so we should try to go through those first before we give up. And then asking your doctor, what are the next steps? Like, what do you see for the future? We don't have crystal balls, none of us do, but we can try to give you an idea of what we're thinking, but just give us some grace that things may change. So we'll have to reevaluate if things don't go the way we hope. Next slide. So, who's who on your team? Probably most of you know this, and it's a little bit different at every site. So, your pediatric rheumatologist is sometimes we use the word attending or faculty. So that's those of us who have gone to medical school. We have degrees like an MD, medical doctor, or a DO, doctor of osteopathic medicine. And that means we did a 3-year residency in pediatrics and then 3 more years of training, which is called a fellowship, just in pediatric rheumatology. Um, and there are some of us who specialize in JDM, have particular interest in JDM, but everyone who's graduated from a pediatric rheumatology fellowship knows how to take care of patients with juvenile myositis. Um, you may also encounter training doctors in your clinic visit. So those fellows, there are 37 training programs for pediatric rheumatologists across the US. You might have a fellow as your primary rheumatologist. They may be the one in charge. Just know that they're always talking with their attending physician, with their supervisor, faculty doctors. There are also pediatric residents and medical students who might be in clinic and might be part of visits sometimes. Each practice has nurses, medical assistants who do different things for families. Some practices, the nurses go into the rooms and are very involved with every visit. Other practices, you don't see them unless your kid needs a vaccine. And then we've got our other subspecialty doctors that help out when JM is affecting other organ systems. I cannot stress enough the importance and value that having a physical therapist, potentially occupational or speech therapist on your team. They are really, really well trained. They may not have ever seen a patient with JM, but there are some resources for training to teach them. And I actually have some physical therapists who learn how to perform a CMAS, and they'll do that with the patients between visits to give me some data, which is super helpful. Your hospital or practice might have a child life specialist, which is one of the coolest jobs in the hospital. Their job is basically to make things easier for kids, help them understand procedures, help them understand treatments, and help them cope. They're really wonderful. Even though you're seeing rheumatology probably much more frequently than you are your pediatrician, it's really important not to stop going to see the primary care doctor. They are going to be helpful when your kid gets sick, and a rheumatology clinic can't see patients when they have a fever or a runny nose. Um, Making sure your pediatrician continues to know your child and what they're going through, that's another huge help. And they think about things that um, rheumatologists may not think about as much, things like puberty changes. So can't forget about that. Your school nurse and teachers really can be allies. And then in our clinics, we may have resources like a social worker, mental health providers, family navigator to help with some insurance and financial issues as well. Next slide. So managing your medical records and patient portals. Patient portals are amazing in terms of many things. They're a way you can communicate with your practice. They're a way that you can read the notes that are taken in clinic, and a way that you can send us messages with pictures. There's also it's also possible to just ask quick questions like, can we get a sooner visit if there's a concern? Um, so making sure you're using your portal to the best that it has to offer. Um, long messages often are better discussed in person by a phone call or maybe a telehealth visit. I certainly am someone who likes to write things down. Um, so if writing out a message is helpful for you, but knowing that it may be best to get an answer over the phone, is something that might be a better workflow or help get you an answer potentially faster. And then it's really important to know when to call instead of message. Some practices have a human who answers the phone. At my practice, unfortunately, we don't, but we have a voicemail line that our nurses check every couple hours during the week. Um, the things that are emergencies I have listed here. So shortness of breath, dizziness going upstairs, lips looking blue, low oxygen levels, those could be signs of the lungs being affected by JM or having an infection. Any choking on foods or liquids. If you run out of steroids or if steroids are being weaned too quickly, your child's adrenal glands that make natural steroids might not have woken up. And so then you go into this something called an adrenal crisis, where patients get dizzy and sweat and vomit and they feel like crud. And that's important to call us if your kid is experiencing symptoms like that. We also sometimes need to give a little burst of steroids, even if patients are on a low dose of steroids and taking it every day when they get sick. So letting us know about things like that. If your child has a fever and no signs of a cold or a GI bug, we want to understand what's going on there. Where is that fever coming from? Severe abdominal pain or blood in the stool could mean that the blood vessels in the gut are inflamed and irritated, and that can cause issues with air inside the wall of the intestines. If you picture like a garden hose cut in half, the wall of the intestine, some air can leak into that, and that can be a medical emergency. Um, and then IVIG headaches, we can help overnight in the evening if needed. And then for patients who have calcinosis, which is generally a sign of later disease, it usually doesn't happen at diagnosis. But if the skin around calcinosis gets red and hot, we're going to have to figure out whether that's an infection, whether bacteria got in there, or whether it's just irritation and inflammation, because those are treated differently. So those are things to call about. Or if your practice actually, if you know as a parent, they actually respond to a MyChart message faster than a phone call, send both, but just be on red alert for those things. Next slide. Internet searches. I'll be brief on this one. You know where to go. You're in the best place with CureJM. The information is top notch. Another organization I found for helping kids cope, especially when they have chronic pain, is called CHIP. The website is mychip.org. ChatGPT is becoming our friends, but remember that it can do weird things like hallucinate. That's what it's called. It can give you false information. So don't take everything as gospel. And then if you're reading about magical cures, magical diets that make things better, if someone's trying to sell you a supplement that's going to cure your kid's JM, really be aware that that's if that was real, we would be doing it. We wouldn't be holding that back from our families. Next, please. And then I just wanted to have a slide to talk about caring for yourselves as parents and grandparents and loved ones. What your child is going through is very, very difficult. What you are going through as parents is exceedingly difficult. This has changed your lives. What the siblings are going through is really hard too. And wanted to let you all know that even if we doctors aren't asking how you are doing as parents, we do care. And if that's something that you need to talk to us about, we are more than happy to listen to it. This is a time when a child develops a chronic illness that some parents use substances to cope, and making sure that you are aware of what's going on with the stress in your life. It's not selfish. It's the idea of putting your oxygen mask on first in the airplane. Um, Hit the button one time for me. I did find this. This is just a little dose of humor. When I was in Austria, I was at a winery, and there's MTX wine, like methotrexate wine. So wine might help you until it doesn't help you. So just wanted to give a plug for caring for yourselves. Next slide. And then I talked about this already. The care models and resources are different in different places. What you might hear from a CureJM family may be very different than how your practice is run. And knowing that your training doctors are supervised very, very closely. And my joke is always that you get two doctors for the price of one, and you really are getting two brains for the price of one. And I learn more from my fellows sometimes than what I would say myself. Also, just understanding that delays and miscommunication sometimes happen. Assume positive intent on the side of your care team, and speak up when you're not getting what you need. Next, please. So I think that this is our final slide here, just a wrap up. Getting a diagnosis can be one of the hardest parts of having juvenile myositis. Some of you may have had a very long road to getting where you are just in terms of a diagnosis. Certainly the treatments and the road is long once the diagnosis is made, but there is a lot of relief once a diagnosis is made, and we do have a lot of plans and fantastic medications to help make things better as time goes on. Remembering that early aggressive treatment gives us better outcomes, even though it is scary. We physicians are always thinking about balancing risks and benefits. We would never recommend something that had more risks than benefits for your kids. Not forgetting sun protection, how important that is, and remembering that you are the center of the care team and taking care of your noggin and your child's noggin, not just their body.